Hello, welcome today to our May 1st event for our virtual MBC Impact Series. Today, my name is Casey Volpe and I am manager of MBC initiatives here at Komen. The programming for this series, for those of you that are joining us for the first time, is envisioned as a year-long conversation where we give new topics and new information to speakers every month, allowing you to pick and choose what's most valuable and important to you at this time. Today, we're covering quality of life through treatment, coping with fatigue and nausea, and we have two absolutely fantastic speakers for you, Dr. Sharon Giordano and Dr. Neelam Patel. We also have a lovely moderator, Cindy Johnson, who is an MBC advocate who will be hopping on in a moment to introduce herself. Before we begin, I have to say thank you to our sponsors for the 2025 MBC Impact Series. So thank you to our premier sponsors, AstraZeneca, Gilead, and Merck, and to our signature sponsors, Daiichi Sankyo and Novartis. We're able to bring this to you every month because of their generosity. So one more housekeeping note, we have a lot of presentations to get through and it's going to be really helpful. However, as you're listening, if you think of questions, please feel free to post your questions in the Q&A feature in Zoom. Once we're done with the presentation portion, we will get through as many as we can. But remember, our speakers cannot provide individual medical advice, so try to keep your questions as general as possible. Towards the end of the program, we're going to drop a survey link in the chat. It would be very helpful if you're able to give us any feedback for how we did today. And now, certainly not least, last but not least, I'm going to introduce you to our lovely moderator, Cindy Johnson. Cindy grew up in northern Iowa with an incredible family. After college and teaching in Texas, then central Minnesota, she and her husband made their home in rural southern Minnesota. There, she was a high school English teacher for 26 years. Cindy and Brad have 4 boys and a beautiful Great Pyrenees dog. Each of the boys are adulting and living successful, happy lives and fill her mom heart with lots of pride. Her husband continues to teach and coach at the same high school where she was employed. They enjoy being part of a close community and caring people. Cindy enjoys boating, walks with her dog, biking, reading, and book clubs, vacations, and time with friends and family. Unfortunately, Cindy received a de novo metastatic diagnosis in March of 2018. A year later, she made the difficult decision to retire early and concentrate on her health and treatments, plus enjoy more time with her family. Cindy is driven by a passion and a sense of urgency to address MBC and the side effects of long-term treatments. She's been active with Tackle Cancer fundraising, Relief for Life, metastatic cancer support groups, and mentoring. She's hoping to make a positive impact and inspire others while serving the Komen's MBC steering committee. And that is how I know her, and it has been a true joy getting to work alongside her and get to know her better. Cindy, my dear, the floor is yours.
Thank you so much, Casey. I appreciate that. As my bio already stated, in 2018, I was diagnosed de novo MBC. And at that time, I wasn't sure of how many years or what my years would look like. And after 7 years, I consider myself kind of a long timer. And as I continue my treatments, my infusions every 21 days, and of course, tamoxifen, I believe those side effects are setting in more and more, or it's maybe aging, maybe both, I'm not sure. But fatigue especially is something I struggle with. And then the nauseousness comes with my particular case of infusions. I get a headache. I'm very, very tired. And if I don't sleep off that headache, the nauseousness kicks in. So I've just learned over the years how to accommodate what I'm dealing with and how I'm feeling. So this topic is especially interesting for me. I'm interested in how much I can do to prevent or at least counteract what I'm dealing with, and how to try to live a normal life as much as possible in dealing with the fatigue. So at this time, that's enough about me. I am honored to introduce our 2 incredible speakers for today. First, we will hear from Dr. Sharon Giordano, who is a medical oncologist specializing in the care of patients with breast cancer. She serves as the Colin Powell Chair for Cancer Research, Chair of the Department of Health Services Research, and she's a professor of medicine in the Department of Breast Medical Oncology at the University of Texas MD Anderson Cancer Center. Her work focuses on quality of health care delivery, disparities, male breast cancer, and outcomes for breast cancer patients. She is currently funded through NCI, CPRIT, and Susan G. Komen. Dr. Giordano serves on the NCCN Breast Cancer Guidelines Panel and co-chairs several of ASCO's breast cancer clinical practice guidelines. She is dedicated to mentoring and developing the careers of trainees and junior faculty as well. Dr. Giordano's work in mentoring was recognized with the Cancer Medicine Mentor of the Year Award, as well as the MD Anderson President's Excellence Award in Education and Mentorship. She received the MD Anderson Excellence in Leadership Award in 2019, the 2020 MD Anderson Cancer Center Jack and Beverly Randall Excellence in Cancer Care, and the President's Recognition of Faculty Excellence Award Clinical Quality Improvement in 2022. In 2024, she received ASCO's Hologic Women Who Conquer Cancer Mentorship Award. And then our second speaker will be Dr. Neelam Patel, who is a clinical pharmacy specialist in breast medical oncology at the University of Texas MD Anderson Center in Houston, Texas. She has been at MD Anderson for almost 14 years now, including her time as oncology pharmacy resident. Throughout her career, Neelam has interacted and developed relationships with patients and their families as they navigate treatment and the side effects. This has been one of the most rewarding aspects of her career and has allowed her to grow and learn in countless ways. Welcome to both of you. At this time, there we go. We will hear from Dr. Sharon Giordano.
Thank you so much. That was a really, really nice introduction, and I appreciate it. So I was going to start the session out and talk a little bit about fatigue in patients with cancer. And then we'll pass it over to Neelam Patel, who's going to talk about nausea. But I thought I'd just start with a definition so we're all kind of on the same page of what we're talking about. And so this was a definition that I took from NCCN guidelines, and it describes it as cancer-related fatigue is distressing, persistent, subjective sense of physical, emotional, or cognitive tiredness or exhaustion related to cancer or cancer treatment that's not proportional to recent activity and it interferes with the usual functioning. So why is this important? I think first and foremost, this is really, really common. Like the majority of cancer patients that are going through cancer treatments, especially chemotherapy, experience cancer-related fatigue. And when patients are asked, they actually describe fatigue as the most distressing symptom related to their cancer and the cancer treatment. So, when I'm counseling people who are about to start chemotherapy, sometimes what they're thinking about first is they're going to lose their hair or some of the other, or maybe they're nauseated. But by the end of it, what's often bothering them the most is just being tired. This impacts patients' quality of life and, can prevent people returning to work after their treatment. So this cancer-related fatigue is subjective. So this isn't anything that we can measure with a blood test, with a CAT scan, with any sort of measure that we have. And it's really assessed just by asking the patient how they're feeling and getting their sense of their own fatigue. The guidelines are now recommending that patients should be screened for the presence and the severity of fatigue, typically like at the first visit, and then on a regular basis, and if things change. And unfortunately, I think the current practices, both for assessing fatigue and for treating it, are often inadequate and not consistent. One thing that we found is that the fatigue from cancer is often underreported, and there's a whole lot of reasons for this. Some have suggested that sometimes patients might be concerned about telling their doctors how tired they actually are for fear that the doctor's then going to alter their treatment or lower the dose. Or maybe they're concerned that the clinical team might think of them as complainers, which of course we don't, but sometimes people feel that way. And then clinicians often just are blind to this as a problem, don't really recognize it, don't see what a severe impact it's having on their patients, and sometimes feel kind of powerless to treat it. Maybe they don't know about the effective treatments for fatigue or really how to manage it, even if patients describe it. So usually we assess this just on a basic numerical scale from 0, which is no fatigue, to 10, which is, the worst fatigue imaginable. And if people self-report as a 4 or more, that sort of tips into the area where they need to be evaluated further for the severity of the fatigue and for the cause of the fatigue. This is a brief fatigue inventory, which is used often as a research tool at MD Anderson's to assess fatigue. And it asks, please rate your fatigue by circulating the one number that best describes it right now. And then it asks you to rate the fatigue at the usual level in the last 24 hours, the worst level in the past 24 hours. And then asks how it impacts you. So how it's impacted your general activity, your mood, your walking ability, your normal work, your relations with other people, and your life enjoyment. And tools like this really are used to help us better research cancer-related fatigue so we can describe it accurately and come up with effective treatments. So when you have fatigue, some of the questions that your care team might ask you are things like, when did it start? How often do you have it? Is it changing over time, better or worse? Does anything make it better? Anything make it worse? And how much does it disrupt your daily life? If patients are reporting significant fatigue, the next step is really working up the cause of the fatigue to see if we can figure out what the main reason for the fatigue is, and if there's things that we can correct that can help improve the fatigue. Some of the things we're looking for, I highlighted the first 3, which are pain, emotional distress, and that could be depression or anxiety, and sleep disturbances, because they're so commonly associated with cancer-related fatigue. Other things we're looking for is medications, like how much medications could be causing fatigue, and that could include like over-the-counter medicines or supplements. The side effects of treatment, obviously chemotherapy itself can make you tired, but also there's some side effects of immunotherapy where it can affect your endocrine system, affect your adrenal glands, for example, and cause really profound fatigue. Anemia, nutritional deficits, low thyroid, or just other medical illnesses that may be contributing. If patients have heart failure, autoimmune diseases, or other medical conditions, those can also contribute to the sensation of fatigue. Evaluating and treating fatigue is really a team-based activity. And this is also from a diagram that I took from the NCCN patient. It's a guideline for patients on fatigue and cancer. And so it kind of puts your care team at the middle, but makes the point that all these other aspects of care can be really important in the management of fatigue. So adequately addressing mental health, helping patients with anxiety and depression if they have them, working with palliative care, typically for patients with more advanced cancer to help improve quality of life, working with integrative oncology teams for activities such as complementary therapies, yoga, acupuncture, and meditation, which can help improve fatigue, helping survivors deal with late effects of treatment, and promoting physical activity. So maybe working with physical therapy or rehab medicine to help improve physical functioning. So how do we typically manage patients with fatigue? One of the important things to start with is education. So just letting patients know that this is a really common side effect related to cancer and its treatment, that it doesn't necessarily mean that their cancer is getting worse or that the treatment's not working, which sometimes is a fear. And then letting people know and kind of what to expect from their treatment. So giving them some basic idea of the pattern of fatigue, whether it might be physical, emotional, cognitive, and how severe the fatigue may be that they can expect from a treatment that they're on. And so I think patients, just when they know what to expect going in, then are able to manage the situation better. I mentioned sleep before as, I guess, maybe a sort of an intuitive cause of fatigue, and can be a compounding issue for cancer-related fatigue. So some of the things that need to be addressed are addressing anything that could cause poor quality sleep. And so, encouraging patients to have regular sleep schedules, to limit daytime naps if that starts to interfere with their sleeping at night, to avoid ingesting alcohol, caffeine, or high sugar foods before bed, and to have quiet, dark, comfortable sleep environments. Other things that can help are like stress-reducing activities such as reading, journaling, yoga, meditation, or quiet music before they go to bed. One of the most important ways we can address cancer-related fatigue, and again, it's not a cure for it, but it can help minimize the symptoms, is to encourage physical activity. And so this has been shown in clinical studies to actually help improve fatigue. We don't know exactly why that is. Perhaps some theories are that it counteracts some low-grade inflammation in the body related to cancer and the treatment. A plan can be help directed by physical therapy or rehabilitation medicine. And again, as I mentioned, studies often show improvement of cancer-related fatigue with exercise. There are some situations, though, that we need to be cautious about this. I mean, sometimes if patients have bone metastases, especially if their bones are at risk for fracture, we need to be careful. If patients have low platelet count, which can predispose to bleeding if they had a fall, if they're very anemic, if they're sick with a fever and infection, have some functional limitations, might fall or had recent surgery. So, I think we just need to put it in perspective. And the recommendations are generally to begin at a low level and then progress slowly as you tolerate it, and then modify if the condition changes. There's also other forms of physical activity that can help, and again, have been shown in mostly small studies, but to have some benefit in cancer-related fatigue. So these can include yoga, which is really using exercise, meditation, and control of your breathing and emotions. There's some data for massage therapy as a helpful form of treatment, and a limited number of studies showing a benefit of acupuncture. I think it's also important to think about psychosocial interventions if they're needed and if the patients are having distress, because there's a very strong correlation between emotional distress and feeling really fatigued and exhausted. Again, this is another area we don't really understand why that connection is, but it's very clear that there is a connection. Some of the approaches can include things like cognitive behavioral therapy. And this is a way to help kind of identify and change negative or unhelpful thoughts to help kind of improve your thought processes and actions. That can also be used for insomnia. Education strategies, such as how to manage stress more effectively, can be helpful. There's some evidence for supportive expressive therapies, and then complementary therapies like muscle relaxation, music therapy, hypnosis, I think journaling, I also mentioned earlier. Some of those have been shown in small studies to have some benefit. Another approach can be the use of a bright white light therapy. So again, the data on this is small. There's not a whole lot of research with this, but the little research there is does suggest that this can be beneficial. And so this is exposure to fluorescent light from a light box. And you've probably heard of this as something that's been used for like seasonal affective disorder for people that live in, dark climates in the winter. So it's been used for mood disorders and sleep disturbances kind of more commonly than for cancer fatigue. But there are some small studies that show a benefit in breast cancer patients. We still don't really know exactly how to prescribe this. We haven't had enough research to know how to time this, how often to use it, how long you should use it. But it is something that's generally low risk and can be used to help address fatigue. And then another, perhaps final approach is the use of medications. So we don't see this used that commonly, but in some select patients, medications can be very helpful. The studies are really hard to sort out on this because there's a very powerful placebo effect that when people take something for fatigue, about a quarter of them just feel better knowing they're trying to do something for that. The data are strongest for methylphenidate, which is Ritalin, which can be used sometimes to help address cancer-related fatigue. Typically, that's used in patients with advanced cancer and after all the other treatable causes have been ruled out. Another approach that can be used sometimes in patients at the end of life is use of corticosteroids for short-term relief. This can help with fatigue and help with lack of appetite. Also, it can be helpful for pain related to bone metastases. But again, this is typically used with patients with fairly advanced disease and not so much for earlier stage disease because of the other side effects and complications of steroids. And then finally, we want to encourage people to conserve their energy. And I think this is especially important with patients with more advanced cancer and even more as you're getting towards end-of-life care. But really thinking about, you know, if you only have a limited energy in the day, how you're going to use that. And are there tasks that you can delegate? Are there times that you can nap? So you're really spending the energy and the time that you have on the things that you like doing and the things that are important to you. Pace yourself, set realistic expectations, postpone things if they don't need to be done right away. And then plan your activities. They'll kind of recommend mapping out over the day, like when you feel best. And so you can plan the things that you want to do during the periods of the day when you tend to feel best, or even the stretches like the days of the week that you feel better, for example, after a chemotherapy treatment. There are a lot of resources out there that you can look to. I think some of the information that I provided to you is really nicely summarized on the NCCN patient guidelines for cancer and fatigue. At MD Anderson, I put a link here to our website. We actually have a whole clinic dedicated to cancer-related fatigue for our patients to make sure we work up all the causes and then offer any treatments that might help. And then Komen has a variety of different resources that we also have linked towards here that can help provide information. So thank you very much. I'm going to stop here and stop sharing my screen and pass it over to Dr. Patel.
Thank you so much, Dr. Giordano. Thank you again for the introduction, Cindy. My name is Neelam. I'm a clinical pharmacy specialist at MD Anderson, and I've worked for several years with Dr. Giordano in the breast clinic. So thank you all for having me. I'm going to talk more about nausea. And I think, unfortunately, we've all been familiar for one reason or another with this feeling of that you might throw up or you want to throw up. Sometimes nausea may happen alone, or it may happen just before you vomit. And this can be caused by many things. So our cancer treatments, unfortunately, can cause nausea and vomiting, which includes chemotherapy or radiation therapy. When cancer is spread to the brain, that can also cause nausea. But there are other non-cancer related causes of nausea, like infection or other medications that can even cause nausea. If someone is very severely constipated or have other blockages in their intestines, that can also cause nausea. So as I go through these slides, I'll talk again about how it's important for us as the care team to hear about what is causing your nausea or when it's happening, so that we may explore other causes if we think that it might not be the treatment that we're providing. So one of the big things with chemotherapy-induced nausea is preventing it before it happens. And so why is this important? Why is it important for us to get ahead of nausea? It may cause you to not want to eat, which may lead to you feeling more fatigued and tired, like Dr. Giordano talked about earlier. It may cause dehydration, especially if it's accompanied by vomiting. It can also add to fatigue that our treatments may cause and increase brain fog. And it can also result in delaying or canceling future treatments, especially if we have patients who have uncontrolled nausea and vomiting. Despite all of our interventions, we may not feel comfortable moving forward with treatment. And so that's why it's really important for us to get ahead of this as much as we can. And understanding as a pharmacist, I know it may seem like I am very much a proponent of taking as many medications as possible. And as much as I don't necessarily love that either. I understand from a patient perspective is you're already potentially taking so many different things, but for nausea, I really try to stress to our patients that if we're asking you to take things on a scheduled basis, we really want you to do that because our hope is that it will help prevent any sort of complications down the line. Some of the things that you may or may not know is that us as the care team or the treatment team, we consider different factors when we're making a plan for you to prevent nausea and vomiting. And so this comes down to it being very treatment specific. So we look at potentially the duration of treatment. So how long will the treatment be? Is it daily? Is it just one day every 3 weeks? The dose plays a large role in helping us decide what types of medications we need to give you to prevent nausea and vomiting. Because some drugs, even if they're given at a lower dose, they tend to cause less nausea, and that same drug given at a higher dose could be considered high risk for nausea. And so that's something that we look at every time someone goes on a new treatment. We look at how often the treatment is given. This may affect how we schedule the nausea medication. So do we just give you something before your treatment, or do we have you schedule something after your treatment? And then also how the treatment is given, that determines also the schedule that we might recommend. So aside from the actual treatment itself, we also look at you all and the patients who are sitting in front of us. And so we look at the age of the patient. Younger patients tend to have more of a problem with nausea and vomiting. The sex of the patients, or females, tend to have more likely to have nausea and vomiting. Your past treatments for cancer also go into that. If someone has a history of morning sickness during pregnancy, when I go in and counsel a patient, if they have had children, I do ask them if they remember how they felt during pregnancy, and that helps us kind of decide, do we need to add an extra medication on? If you did report that, you did have morning sickness, during pregnancy. Another risk factor we consider is motion sickness, as well as history of drinking alcohol. So those who have less exposure to alcohol tend to have more nausea and vomiting. And then feeling anxious can also add to the risk of having nausea and vomiting. And then, of course, other medications. If you're on other medications that may cause nausea and vomiting or add to that, that's something that we also consider. When we look at nausea and vomiting, there are different types. And so I usually, when I talk to a patient about their treatment, I usually explain why we're giving the medications we're giving and what their goal is, or what type of nausea they're treating. So there's 5 different types here. Acute nausea and vomiting is what we see happening within 24 hours of the treatment. It usually peaks about 5 to 6 hours after the treatment. And what we usually do in this case is give what we call a pre-medication, or a medication prior to the treatment to prevent that from happening. Delayed nausea and vomiting is what happens. It can happen at 24 hours after treatment, 24 hours or more after treatment. And so depending on the regimen or the medication that you're being given, some drugs can cause delayed nausea and vomiting, like cyclophosphamide, or one of our antibody drug conjugates that we use for breast cancer more recently. And so we may schedule medications for you to take after your treatment to help prevent delayed nausea and vomiting. Anticipatory nausea and vomiting is common in our population of patients with breast cancer. And it is related to anticipating or feeling anxious about a treatment, or if you've had a prior negative experience, understandably, with treatment. Sometimes even the environment that you're in, walking into the clinic or the hospital may also make someone anxious and add to their nausea. And in that case, we tend to use anti-anxiety medications to help with that, which work really well prior to treatment. And then we have breakthrough and refractory nausea and vomiting. So breakthrough is when we're giving you the appropriate medications and they're on board, but then we're having to change or use a different type of medication to help, because you're essentially the nausea, you're breaking through, or you're having vomiting despite taking all those medications. And refractory is something that happens with every treatment despite us making these changes. This table and the next table have just a list of anti-nausea medications that we commonly use. And so these all target different parts of our body that naturally trigger us to have nausea and vomiting. So our bodies are wired in such a way that if something harmful is ingested or in our stomachs or intestines, it naturally says, oh, something's wrong here, I need to get rid of this. And so with chemotherapy, there's different parts of our bodies that are triggered by this. It's a lot of communication between the brain and receptors in your GI tract, so your stomach, And so the drugs that we use to help prevent nausea and vomiting have come a long way in the last several years. We have a lot more medications to help than we did even 15 years ago. And so that's the mechanism of these, is to help kind of counteract what our body naturally tries to do. So serotonin antagonists or 5-HT3 antagonists, I'm sure many of you are familiar with, are listed there for you. Ondansetron is a very popular one, Zofran. Palonosetron is a Loxy that's only given by IV. And then there's neurokinin-1 antagonists that work with something called to block substance P, that is usually related to pain that can cause nausea and vomiting. But in this case, we also use it for chemotherapy induced nausea and vomiting prevention. And these drugs tend to help with delayed nausea and vomiting as well as acute. And so some of the more commonly used ones are fosaprepitant or Amend. And some of the newer ones are like Rolapitant, which is Varubi, which is a tablet. One of the medications that we have been fortunate to be able to use in the last several years and is in the NCCN guidelines is a medication called olanzapine. This has been historically used as for many years as an antipsychotic medication or a mood stabilizer, but we found in the last several years that it works very beautifully in preventing nausea and vomiting with chemotherapy-induced nausea and vomiting. And so we use different doses, and we actually have found that even the more studies that people are doing, that we can actually use a very low dose of 2.5 milligrams, and that helps many of our patients, but we can also use a higher dose up to 10 milligrams. The biggest side effect with this medication is actually sleepiness or drowsiness, and so we tend to recommend that people take it at bedtime. Corticosteroids have been around for a very long time. Our corticosteroid that we tend to use for nausea and vomiting is dexamethasone. It comes in a tablet form or an injection or IV. It has its own set of side effects. So this goes back to, looking at our patient and making sure that it's not affecting them adversely, because dexamethasone can affect your sleep. It can also increase blood sugar. And so we want to make sure that it's appropriate for the regimen that we're using, but also appropriate for the patient that we're treating. I mentioned anti-anxiety medications briefly before, but benzodiazepines are also a type of medication that we may use. So, but lorazepam or Ativan is the one that we tend to use as mostly for anticipatory nausea. So that feeling of being anxious, this helps with that type of nausea. And then dopamine antagonists were our first drug class of anti-nausea medication. So many, many years ago, we started out with metoclopramide or Reglan, which still has a place today in practice, but we don't use it quite as much. These medications often are used for breakthrough nausea. And they have their own set of side effects. Mostly, sometimes people can feel kind of jittery on them. Sometimes people can feel very sleepy on them. And so, again, something to consider is the patient's age and other issues that they may have before we recommend this medication. And then we do have a class of drugs that we use sparingly, which is the cannabinoids, so dronabinol. And then some people may be familiar with this medication, scopolamine, for usually it's used for motion sickness. So if I ever hear that a patient is having trouble with nausea and vomiting, I usually go in and ask them several questions before I talk to the rest of the team and help come up with a plan. And one of them is, if you're having nausea that's related to movement, or you're laying down, you're standing up and you're getting really nauseous, something like that, then this may be a good option. But again, it may not be a great option for someone who is older or someone who may be a fall risk. And so we just want to make sure that we're talking to patients about these different options and kind of what's causing the nausea, when does it happen, what makes it better, those types of things. So when I go into counsel patients, we usually talk a lot about nausea and vomiting because understandably, this is one of the biggest concerns in our patient population when we're treating them. And so aside from medications, there are other things that we recommend to help cope with nausea. And one of those is drinking plenty of fluids. We recommend 8 to 12 8-ounce glasses of water each day. If someone is vomiting, we can recommend fluids with electrolytes. Sometimes people find that ginger ale helps kind of settle their stomach. We also recommend that people eat smaller meals throughout the day as opposed to eating 3 big meals throughout the day. Sometimes even an empty stomach can cause more nausea. Peppermint candy might help. Sometimes like really spicy or greasy or fried foods can irritate your stomach. So I always kind of give patients a heads up that may not settle as well in your stomach once you start treatment. And then foods that are at room temperature or cool may be more appetizing. We think mostly because of maybe the smell is less pronounced as compared to a heated food. So speaking of smells, it may be that once you start treatment, some smells that didn't bother you before may start to bother you while you are on treatment. And so, things like perfume, there's certain foods that may irritate people, scented candles, hair products. And so that may be something to look out for and try to avoid as much as possible. There are some scents that may help. One thing that I thought was interesting was smelling a newly opened alcohol wipe may help with nausea, peppermint, and then just being able to be outside and getting fresh air can also help. We're really fortunate at MD Anderson that we have dietitians and nutritionists on board where we can have our patients talk to them if they really are struggling with different foods or things not tasting as good. And so that would be something also that I would recommend. So we also have options for complementary therapies. So complementary therapies are ones that are to be used. We use them alongside our recommended standard therapies. So not in place of, but kind of alongside. So acupuncture, Dr. Giordano mentioned this for fatigue. We have also seen it used to help for nausea. Acupressure is a little bit different. An example of this would be one of those bracelets that people use for seasickness or motion sickness. Behavioral therapy may help by changing kind of the way that you think or patterns in behavior. And then there are relaxation techniques that are also recommended. So breathing exercises, meditation, muscle relaxation, guided imagery, and then music therapy. Hypnotherapy also has been recommended before as something that can be tried. And then ginger root needs more research, but it does, but some patients do find relief using like a ginger candy or a powdered ginger or ginger flavored foods. And usually if I have patients who ask about ginger root, I find it to be okay. From a safety perspective, is that's kind of the first thing that we look for. So let's say we try all of this for nausea and then you still vomit. And so the recommendation is to sit and rest for 15 to 20 minutes, to rinse out your mouth, and to start with small sips of water or suck on ice chips. Also like a popsicle or hard candy can help. You can chew gum, which may help settle your stomach. And if you can keep the water down and you feel like eating, you can start with bland foods. So crackers, toast, rice, applesauce, and bananas. And it's important that if you do vomit, to sit upright after you eat, if you are able to eat, so that you don't necessarily cause yourself to vomit again if you lay down. And so one of the big things I try to stress with our patients when I talk to them about their treatment is that everyone is different. So we may come up with a plan for you that we think will work and we hope will work for nausea, but everyone's different. And so one person may tolerate the same treatment very differently from someone, someone else. And I really try to encourage our patients to share your experience with your healthcare team. Keep a log or a diary, because a lot of times when I go in the room, if someone is having trouble with nausea and vomiting, I'll ask questions like, when did it start? What made it better? Did anything make it worse? Or, and there's things that we potentially may expect. So nausea may be worse with a certain regimen, 2 to 3 days after, but then if you come in and say that you vomited, 2 weeks after your treatment, then I may wonder what else is going on. So we tend to ask a lot of questions, and that helps us help you. And so if keeping a log or a diary helps with that, we would recommend that. And also encourage patients to communicate in between treatments if what we recommended for you to prevent the nausea and vomiting is not working as planned. Please don't wait 3 weeks or whatever the interval is before you see your care team to tell us that you were really miserable with nausea and vomiting, because maybe we can do something to help before your next treatment. The other thing to consider too is that sometimes, heartburn can add to the feeling of nausea. And so we may need to recommend like famotidine or Pepcid or something like that to help. And then sometimes nausea can also be related to motion. And so there's different reasons for the nausea, which is why it's important for us to know what you think might be triggering it. The other thing I try to tell patients too is that, we don't want you to tough it out. I think that people have tendency to feel like they may not, like Dr. Giordano kind of talked about before, is like that you feel like you're complaining, but it's really not. We want to make sure that we are helping you the best we can. But if we don't have, sometimes if we don't have that in all of the information, it's harder for us to help you. So I'd like to kind of end with, again, nausea and vomiting management is not always a one size fits all. And we really rely on you all to help communicate your experience with us so that we can help you. The other thing too, I'd like to encourage you all to do is to share what you have tried or are considering. So sometimes people will share like all of the prescription medications that they're on or taking, but they may not share the supplements. And the reason we ask about supplements and other complementary medications is because they're maybe drug interactions or they may be adding to the nausea. And so we want to talk to you about it. So open communication is really important. And then also if you have any hesitation with what we've prescribed for you, it's important to have that open dialogue so that we may help explain why we prescribed what we did, if that's going to help, encourage you to take it. And then if we need to make a change based on your experience, then we can. But at the end of the day, we want to help you. And so I really just encourage you all to communicate with the team and let us know what's going on with you. And I've shared the same resources here that Dr. Giordano did. And so I'd just like to thank you again for being here today.
Thank you both very, very much. That was the most incredible, valuable information I think I've heard as far as side effects and coping with all of the side effects that patients sometimes deal with. I just want to remind our audience that if you still have questions, to go ahead and type those into the Q&A, and I'll try to field as many of those as we can in the time that we have remaining. I'm going to start with the first question. So what types of, and Dr. Patel, I know you sort of touched on this, what are some types of the social and emotional support do you recommend to your patients to help deal with their illness and the side effects?
I can take a first stab at that. I mean, I think it depends a lot on the patient, and I think everybody's a little bit different in what sort of support and resources that they need. I mean, I think we see some people that, really rely very heavily on their family, on their close friends, and kind of maybe they get what they need from that, or they're very private and that's sort of the zone that they're very comfortable with. Sometimes I think that patients benefit from talking to a counselor or a therapist, or kind of somebody who's sort of, outside the emotion of their immediate family or friend unit, to kind of help them think through, how to manage the stress of their illness and how to best, just I guess how to manage it most effectively. And then I think also for some people, support groups can be really helpful. Although I think it kind of depends on the person. Some people don't like to be that public, and other people get tremendous benefit from sort of sharing their experience. And sometimes that can be more on the educational side, where it's just kind of getting information, and then other times it can be more emotionally supportive of sharing stories, kind of similar experiences, so people don't feel alone and know that, other people have gone through it, and that can be very inspiring. So I think it's not a one size fits all, sort of like the same as Neelam said for the nausea. It depends on the person and depends what really can help them and benefit them. But all of those are, potentially available to people. The Komen website has a lot of information and links to support groups. So if people are interested in a support group, you can go there and they can help you find, a group in your area for what you're looking for.
Awesome. Dr. Patel, do you have anything to add?
No, I agree with that. In addition, I would say that if you're where you're being treated has a supportive care group or a team that can help manage those supportive care issues, which is some of this is that, like nausea, especially if it's not related necessarily to the treatment that we're giving you, and maybe it's something else, that could be really helpful. So I think taking advantage of other like services that might be offered at your hospital, especially like integrative medicine or supportive care, could be helpful as well.
I think also if people are part of a religious group, they can also provide a lot of support through kind of their church or temple, kind of working with the religious ministry there. Sometimes that can be really helpful for people.
Sure. Awesome. Thank you. So I know you both have touched on this as far as keeping a log or a journal or a diary as far as with side effects and not toughing it out to express what's going on with your doctor. But how does a patient know what's sort of expected versus what's abnormal and when to actually sort of be the squeaky wheel and complain about it? Do you have any tips for that?
That's a really good question. So I can speak to kind of my experience and how we were trained and how things work here. And we're really fortunate that we have this multidisciplinary team. We have the nurse, the physician, the nurse practitioner, PA, and there's a pharmacist on the team too. And so one of the big things when I go in to talk to the patient is try to make sure that they know that everything I am telling you, if anything happens outside of this window, you need to tell us, right? And it's a lot of information. And I think, again, most people's natural tendency, it seems like, is to try to tough it out. And so I think just encouraging them to do that. I mean, it's really hard to know what's out of the ordinary, but some of that is just if you just share everything with us, we'll know what's out of the ordinary and kind of be able to help you from that standpoint.
I think it is really important to keep track of things as much as you can. I mean, I know it's hard, especially if people don't feel well, but when you don't feel well, you don't remember exactly what happened. I feel like even when I do feel well, I don't remember like if I had something that happened 3 days ago or 6 days ago. So, I think being able to write things down really, really helps when you come back in. It can also help bringing a family member or a friend with you to the visits, either somebody that was with you at home and might have seen what you experienced. I mean, sometimes we'll find that, again, patients, again, want to be tough and don't want to say like, don't want to really express how bad it actually was. And it takes the family member or the friend to say, no, you were actually really sick. You felt horrible. You didn't get out of bed for 3 days. And they're like, oh, no, I feel fine. And they, people don't want to, again, they just sort of want to be strong. But we want to know that because sometimes it's things we can fix and make better so that people don't have to go through that a second time. So sometimes the family or the friends can kind of help fill in the story. And maybe they can also help when we give so much education at patients, they can be another set of ears. So when you go home, they can help you say like, oh yeah, the team said this might happen, or be like, oh, I don't remember hearing that again. So just another set of ears both ways, I think is really helpful.
Sure. Yeah, from my own personal experience, I just think that fatigue is part of the deal. It's part of what you expect. And so it's hard to distinguish how much I should say versus, well, of course, you're still getting treatments. And yeah, so it's a tough line, but yeah, you're right. We need to tell.
That's a good example. So when it comes to fatigue, it's like we're taught this sense of what is expected. And so I share that with the patient, but then I also say, but if you're in bed for days at a time after your treatment, that's not expected. That's not what we want. So I've learned that over the years is sharing kind of the unexpected, or like the things that we don't expect, because again, I think it makes people maybe more comfortable sharing that is happening.
Okay. So question from our audience that's a little more specific. How long does nausea last after chemo? If a patient completed 12 rounds back in December and still has to take Zofran daily, is that something that's typical? How long should this be expected?
I don't expect that to happen if treatment was finished in December. So I think that's something that if they haven't already, they should share with their care team, because that's abnormal for it to last that long. And it depends also like what treatment they got. Things like immunotherapy, some side effects could be long lasting. And so I would say, would you agree, Dr. Giordano?
Yeah, no, that's actually a really good point. It kind of depends on the treatment. Like for chemo, we would not expect the side effects, with the exception maybe of like fatigue and neuropathy.
Sure.
We wouldn't expect something like nausea related to chemotherapy to still be going on, you know, a year or 6 months, whatever, a long time after treatment. But it can cause things like, you can get gastritis or something from the medicines that you're on that can make you nauseated that might not go away right away, or heartburn. I mean, so there's a lot of things that maybe can be related to the chemo that aren't a direct side effect of the chemo, but those kind of things could certainly persist and be further worked up. And then I think Neelam's point's really good about the immunotherapy. Those can have some side effects that persist a lot longer than traditional chemotherapy. So again, it depends on the situation, it depends on the drugs. But and I think symptoms like that are persisting months after treatment are probably something that needs to be brought up with the care team and discussed, so you can kind of sort that out.
To follow up with that, a little bit of my intro, I had talked about how I consider myself a long timer. Do you believe that it gets worse over time when you're continuing with infusions every 21 days, even with immunotherapy or the other therapies?
I think it depends. I think it depends on the treatment. It depends on the dose. It depends on the interval. It depends if there's breaks or not. Sometimes there is a cumulative effect of sort of people that are on longer kind of get more tired, and sometimes you have to take short breaks in the treatment or to change the dose of the treatment, or find ways to adapt to it so it's not really severe. It's kind of different for people with early breast cancer that we're doing a very time limited treatment that we expect to cure the disease. I think then we're trying to get the full treatment in the time frame and sort of encourage people to sort of work through the symptoms that they're having. And it's a really different thing when you're treating advanced cancer, when then you're really trying to make a very different balance of treating the cancer effectively, making people feel well and live longer, but also giving them a life to live so they're not feeling so miserable that they're on the treatment. So I think it depends a little bit on the goals of the treatment, for the approach that we take to that. So for advanced disease, I think sometimes we do need to build in kind of a little bit more breaks in treatment or accommodation so it doesn't continue to worsen over time.
As far as long-term treatments and over time, as you both know, and everyone I'm sure on board here knows, depending on the treatment, the side effects of, say, losing your hair or feeling nauseousness and fatigue and all of those things, it varies depending on your treatment and what you're going through. But for a person who, with metastatic breast cancer, who might not have ever had chemo and might not have ever lost their hair, sometimes patients talk about how people say, but you look so good. How much longer do you have to do these treatments? Oh, but you look so good. You must be feeling really well. Do you have any suggestions for a response without being rude, but like your go-to that you might experience with patients who might be hearing that?
That's a tough one. We hear the other
Yeah.
one too of people that have lost their hair and have people come up and make really kind of unkind remarks. And like I had one patient who it was on cancer treatment and had lost her hair, and she was like at the store with her child, and somebody was like coming up and saying, oh, the last person this happened to died so fast, something in front of like her 10-year-old, and she was kind of mortified. I don't, that's a hard question to know how to answer appropriately. How have you like come up with good approaches for that?
You know, I always have a comment of every day's a good day, because
Right.
there's a day, and I want to say, well, it takes a lot to look like this, but I also know that I did have chemo, lost my hair, and then went to immunotherapy, and so my hair came back, obviously. And
Right.
so now people assume I'm cured, people assume that I'm fine now, that sort of thing, but they don't realize that I could be experiencing side effects.
I think it's like the education and awareness. People think, oh, you lost your hair, that means one thing, but you have stage 4 breast cancer, you have your hair, and I think people maybe just need more awareness and education. But I don't know how you can kindly respond to something like that. That's tough.
It's well-intentioned.
It is. Most people, yeah, it comes from a good place, but it's just
Yes.
what it means to you. Yeah.
I guess
Yeah.
it depends too, like how much you want to share or not share with people, like, because like you
Good.
said, and I'm sure it's well intended and it's, it's complimentary, but it's also, maybe not really understanding.
Yeah. Whether or not it diminishes what you're really going through or
Exactly.
experiencing.
Yeah.
Right.
Reality.
Yeah, exactly.
Yeah.
Yeah.
Like implies you're not sick or not having any problems or not. Yeah.
Yeah, exactly. Well, I could obviously ask you a million different questions, but I want to thank you both so much for your information and your slideshow. This is being recorded so people can tune in later and take more notes if they need to, or go back and review this information. But I believe this is all the time we have for questions, as we're running out of minutes here. So Casey, do you want to lead us into the evaluation?
Yes, thank you so much, Cindy. So first and foremost, a big thank you to our two fabulous speakers and our moderator, Cindy, for leading this discussion today. We got a couple comments saying it was really helpful and thanking you guys, so I want to pass those on as well. Like Cindy mentioned, it was recorded, so we're going to post it to Komen's YouTube channel and send it out to everyone who registered. But in the meantime, you can visit komen.org/MBC series and watch previous webinars, pick and choose the topics that would be most supportive and valuable to you right now. And enjoy while we wait for this recording to get buffered up and running. So just have to thank our sponsors one last time. So thank you, AstraZeneca, Merck, Gilead, and of course, Daiichi Sankyo and Novartis. In the chat, I dropped a link to the survey. I promise it actually gets read by me. I'm the one who does it. So please take a moment and let us know how we did. Let us know what topics you'd like to hear more about. If you're struggling to find information out there and you want us to try to cover it, let us know, and I will make sure that it gets put into the programming. That's how we pick these topics, is feedback from you guys. So it's really helpful for me. It only takes a couple minutes. Finally, the next event for the MBC Impact Series will actually be May 28th, and we'll be focusing on coping with anxiety and loss while living with a stage 4 diagnosis. So I hope that you find that topic valuable. If you do, you can register now on our landing page, again, komen.org/MBC series. Otherwise, thank you for joining us today, and stay safe and stay connected.
Thank you.
Thank you.